Hi everyone. Welcome to my talk as part of the New Stars of Data conference. I'll just quickly introduce myself. My name is Andrew Cushing, and I have a keen interest in healthcare innovation, which is going to be the focus of my talk today. So I kind of gained this interest through originally studying pharmacology at undergraduate level, and I went on to study precision medicine and pharmacological innovation at master's level. And through this, I kind of gained an understanding of the healthcare innovation landscape. And I went then on to join the technical side of healthcare research when I started a role as a data analyst at Linus Health, which is a digital healthcare startup based in Edinburgh, here in Scotland, which is focused on developing data-driven solutions to the many issues facing healthcare systems at the moment. So the work that I'm going to show today relates to some investigative work that I'm carrying out as part of my role at Linus, which looks at ways of communicating data and machine learning derived insights on patient populations to primary care providers and coordinators using Power BI dashboards. So I'll now give a broad overview of the structure of this talk. So this talk will explore a specific use case for Power BI to coordinate care in the NHS in the UK. So it's going to be very use case focused. So I'm going to start by discussing machine learning adoption gap in healthcare and explore some of the primary ways in which the barriers facing machine learning models being adopted into live practice can be overcome and the role of Power BI in this. And I'm then going to finish off the talk by providing a demonstration of illustrative Power BI dashboard views that could be provided to better manage patient populations in primary care, and also explain how I create these. So what can you expect to get out of attending this talk today? So for those of you without healthcare background, this talk should hopefully provide an insight into why the adoption of machine learning models has been limited in the healthcare setting to date, despite there being long-term interest in using machine learning in this setting, and also provide insight into how some of these barriers can be overcome and the role that Power BI could potentially have in this. So for those of you who use Power BI as a tool or are interested in starting to use Power BI as a tool, this talk will also hopefully allow you to discover some new ways to harness the functionality of Power BI through exploring this specific use case, and hopefully some things that you could take on to your own work as well. So to start off the talk, what are the core issues that are facing healthcare systems at the moment that are leading to the strains on services that we hear about a lot in the news? So firstly, the COVID-19 pandemic unsurprisingly led to severe service disruptions, and a result of this is huge backlogs in waiting lists for routine hospital appointments. So for context of how bad the current picture is, using NHS data in the UK as an example, in June 2023, there were 7.5 million people on the waiting list for routine hospital appointments, and around 390,000 of those people had already been waiting for longer than a year. But as you can see on the graph from the current slide here, this isn't just a pandemic-induced issue, and you can see in the 10 years prior to the pandemic, that wait list had already doubled. And so there's kind of this continual trend that's been exacerbated and steeply gone up, but this is a long-term issue. So another kind of core issue that's been exposed and also exacerbated by the pandemic is staffing, recruitment and retention issues within healthcare systems that are driven by dangerous working conditions, payment concerns, and other factors like that. So some recent stats on this. The World Health Organization's Europe report, Time to Act, which looked at this subject of people leaving the healthcare industry, showed that there were around 70% of healthcare workers report experiencing burnout. And other surveys have shown that 55% of frontline clinicians say their experiences during the pandemic had decreased their interest or ability to continue working in their field. So the result of this is there's around 1.8 million vacancies in the WHO European region, which is estimated to more than double by 2030 if current trends are to continue. So these shortages are essentially leaving hospitals stretched, and hospitals are reported lower staffing ratios, more overtime, shorter visit lengths, and greater use of agency staff as a result of this. So another core challenge that's facing healthcare systems is the growing number of people with chronic diseases. So for context, chronic diseases or conditions are diseases which cannot currently be cured and require continuous medical treatment, such as osteoporosis, chronic kidney disease, diabetes, COPD, cardiovascular disease. And as populations have aged, the number of people living with these conditions has continued to increase. And so the capacity of healthcare systems is going to need to expand to keep up with this. But already healthcare systems are struggling to manage patient populations with chronic diseases, particularly around preventative care, because increasing proportions of budget is needing to be spent on emergency care when people land up in hospital, because that preventative care hasn't been done in the first place. So it's really not a good model. So the collective impact of all these challenges mean that there are delayed diagnoses, reactive approaches to disease management, meaning that patients start therapy at a later point as they are diagnosed at a later point, and also when adaptations to their therapy are required because their disease severity increases. This doesn't happen predictably, as I mentioned before. It happens in response to things like people going to hospital, and that model of care leads to very negative long-term outcomes for patients, and is also very costly for healthcare systems, as hospitalizations are one of the main costs that healthcare systems will pay. So yeah, another core challenge and something that's very important to mention is healthcare inequalities. And particularly the significant gaps in life expectancy and healthy life expectancy between people that are living in more deprived areas and people that are living in more affluent areas. So yeah, on the current slide here, this is looking at data from England and males and females stratified by how deprived the area they are living in is. And you can see there's a clear trend here where people in more deprived areas have a shortened life expectancy and healthy life expectancy. And at the extremes of the scale here, in England, you can see there's a 20-year difference in healthy life expectancy for women living in the most deprived areas and women living in the least deprived areas. So yeah, a really stark contrast there, which is something that needs to be addressed alongside the other issues facing healthcare systems to ensure that healthcare systems are not only more efficient, but more equitable as well. So yeah, how does machine learning hope to alter this picture? So machine learning has a number of key potential roles within healthcare systems, which are at various stages of being realized. So the proposed benefits of machine learning for use in impacting patient care directly include time and resource savings from the automation of tasks outside of patient-facing care, and also the aggregation and analysis of individual and population level data to support early and accurate diagnosis, triage of patients, and also potentially treatment selection. However, the roles of machine learning aren't just in directly impacting patient care. Some of the wider roles include things like better workforce planning to ensure the correct people and tools are in the right places at the right times, so the healthcare system can run more efficiently. Yeah, there's been a range of data types that have been used in machine learning applications to date. That have been reported on in the literature. So this is include structured data contained within electronic health records. So this could include things like admissions, labs data, and so on. There's also semi-structured data, such as time series data that might be acquired by wearable medical devices, and also unstructured data, such as medical imaging data, radiology data, and so on. So despite extensive reports of various different machine learning models in the academic literature with healthcare purposes, there's been very limited translation of these models into tools used in live clinical care. And there's a number of reasons for this, which I'm going to talk through just now. So firstly, this is partly due to the healthcare context being such a high-risk area for using machine learning. Consider this, for example, machine learning is being used to predict what music to listen to a Spotify user, and the user doesn't like the song, they simply skip the song. However, if machine learning is being used to predict the patients that are at highest risk of going into hospital in a resource-constrained health service, the implications are much more severe. Patients that aren't being brought forward but should have done could quickly land up in hospital, and where patients didn't actually need to be brought forward, this can cause stress and anxiety to patients and also misuse of very limited resources. So another factor is it's also generally believed amongst the public, medical professionals as well, and patients that there should always be a human medical professional in the loop when a model is making decisions that are impacting patient care for safety reasons. However, this is very complicated to do in reality using machine learning models as they are, because most of them are very difficult to interpret how the inputs are arriving at the outputs. So this makes this human in the loop model quite difficult. Additionally, the potential implications of introducing bias models that are performant for one group that the model is intended to run inferencing on, but not another, need to be considered, as this can lead to or exacerbate existing healthcare inequalities if the model is improving care for one group but not for another. So lastly, and something that's not talked about enough in my opinion, is the lack of clinical user co-design and oversight in model development, with many models being developed in a siloed way by academics publishing papers on model performance in a training dataset and hoping clinical teams will somehow read the paper, see the model is performant, and then go on and do the required evaluation, operationalization, and monitoring steps themselves, which is very unlikely to happen given the time constraints on these teams and their different expertise. So this lack of co-working and planning for model operationalization has hampered the use of machine learning models in clinical care, and meant the concerns around machine learning have not been addressed, such as the fairness and explainability concerns that I mentioned before. So what is required to reduce the machine learning model adoption gap in healthcare and mean these models are available in order to improve care? Well, ultimately, this is going to require clinical trial evidence of the safety, utility, and feasibility of using models in clinical care to impact decision making. However, to get to this point, a collaborative working approach involving clinical teams containing clinical experts and routine clinical users and technical team containing data scientists and engineers is required to work through the complex challenges and hurdles that need to be overcome to develop and operationalize models into a live clinical environment. So significant consideration needs to be put into what predictions models are making and how they are actually being used day to day clinically. So this decision will need to be driven by clinical care teams necessitating this co-development model. This is because created models need to be able to brought into existing pathways to aid clinical care teams with decision making by providing actionable insight. And therefore only those with experience of these current pathways and clinical knowledge can best determine where the models can add most value. Additionally, there needs to be consideration throughout for actionability, explainability, and fairness. So clinical involvement is required to determine the bioplausibility of models. And what I mean by bioplausibility is what the model is predicting is making sense clinically and physiologically. So this kind of comes back to the human medical professional in the loop. But as I said before, this is complicated. So the sort of technical team behind the models need to come up with a way that models can be interpretable to those using them, both at a global level, so how the model is working overall, and also at a local level, so for an individual prediction. And yeah, also that idea of fairness throughout this process of development within that team. Fairness needs to be considered across demographic groups to ensure that you're not introducing a model with better performance in one demographic group than other, leading to clinically unacceptable biases and healthcare inequalities. Equally, considering how the model outputs will be available to different stakeholders so they can action them should be considered as important as developing performant models. And this may require quite a lot of thinking and co-design efforts, especially as there may be a range of different stakeholders clinically who need to access and understand the model-derived insights And these users may have different levels of technical understanding, different levels of disease-specific understanding, and will have different needs to fulfill their role and available time. So this means that different tools potentially need to be available to different stakeholders in order to make sure that the model outputs are interpretable and accessible for them. And also, as patient data is highly sensitive, it's important to consider what groups need access to what levels of identifiable data of those different stakeholders. So this means that separate tools may need to be provided for those people in different groups. So sneak preview, this is where Power BI could potentially come into the picture. So I'm now just going to explore our journey to date within our multidisciplinary team, working to co-develop and operationalize risk prediction machine learning models within our multidisciplinary team, containing clinicians from NHS Greater Glasgow and Clyde and a technical team from here at Linus Health. And I'm then going to go on to describe where Power BI could potentially be used to further the impact of the work we've done to date. So yeah, the project started together by bringing together our team consisting of respiratory consultants, so really specialist doctors from NHS Greater Glasgow and Clyde, and data scientists, data engineers, software developers, and others from the Linus Health technical team to work on the development of risk prediction models for chronic obstructive pulmonary disease, or COPD, which is a very common respiratory condition which is characterized by breathlessness and lung damage. So yeah, just to give some context of why the COPD focus of our work was selected, that was due to the impact of COPD within the NHS, the healthcare system where we were hoping to operationalize the models. So just some key stats here. COPD is responsible for 30,000 deaths per year in the UK, 1 million occupied bed days, and also over 675 million pounds in 2022 was spent just on admissions for COPD, so that's not including treatment or anything else. This is purely hospital admissions, and so you can see from this that COPD has an enormous burden, not only for the patients that have them with very poor outcomes, lots of time in hospital, but also for the healthcare system, with it being very expensive to manage with the current sort of reactive approach to disease management. So yeah, we went through a step-by-step co-development process to develop the models we've developed. So throughout the process, explainability, actionability, and fairness were at the forefront of any decisions that we made. So yeah, firstly, starting with explainability. Yeah, as I mentioned before, a lot of models are very difficult to interpret how the inputs to the model are arriving at the output. So to kind of get around that, we were using sort of tree-based models, which, although more interpretable than some other models, are definitely not interpretable when you're introducing all these different features on their own. And therefore, we looked at introducing the model agnostic SHAP framework. So for those of you that aren't familiar, SHAP essentially allows you to determine how much each feature is impacting a particular model prediction in order to get local level explainability. So explainability for that prediction. And then the SHAP values for each feature for each prediction can then be aggregated to determine the overall impact of the different model features on model predictions. So throughout the process, we showed explainability using visuals similar to that shown on the current slide here, which we would talk through with the clinical team in depth to determine if the models are bioplausible, i.e. if they're making sense. So this is essentially the top 20 features that are impacting model predictions, with red meaning higher values are associated with predicting mortality in this case, and blue meaning lower values are associated with predicting lower values are associated with predicting mortality if it's on the right side, and vice versa. So yeah, so we'd show these explainability views in order to determine bioplausibility. So this essentially means, for example, if something like age was saying lower ages are associated with lower ages are associated with higher risk of mortality, or higher ages are associated with lower risk of mortality, this wouldn't make clinical sense, and it would be clear there was a bias at play that could then be investigated by the team. So that's one aspect to the importance of explainability, but it's also important to explain how the model is making a decision so that actionable features can be identified. For example, it may come up in one of these plots or whatever explainability view is shown that a patient hasn't had a recent vaccine, for example, and quite often this data is harder than you think for clinical teams to access. So providing this aggregated view of factors that are driving risk and being able to identify actionable features vastly increases the clinical utility of the models by providing actionable information at a really aggregated and clear level. So yeah, the other element to something that we tried to consider throughout was model fairness, and this was consistently factored into our co-development process to ensure there weren't clinically unacceptable biases. So we looked at a series of performance metrics for various different demographic groups, as you can kind of see on the current slide here. So this is for a mortality prediction model, and this looks at precision, recall, F1 score, and positive selection rate between males and females. For those of you that aren't familiar with these metrics, precision looks at for all the predictions at a certain threshold where mortality was predicted, in this case, for how many of those instances that was correct. Recall looks at for all the instances where mortality did occur for this prediction at this certain threshold, how many of those were captured. Positive selection rate is simply just the proportion of predictions where mortality was predicted, and F1 score is a harmonic mean of precision and recall. So yeah, you can see essentially that these metrics are fairly similar between males and females, indicating in this case that there's not any concerning biases present, which is obviously good. So yeah, in order for us to be able to use models in a live clinical environment, we had to make sure they were safe to use, they were performant enough to use, and they were bioplausible and fair. So in order to do this, we kind of had a structured model approval process that would involve the whole clinical and technical team, and we worked through this checklist here in order to determine if all these key points had been met. So if all the technical requirements had been met, if the training and holdout sets were comparable, is the model formulation suitable, is the algorithm suitable, are the model's features being engineered correctly, is the model suitably calibrated so the prediction scores are accurate, and yeah, as I mentioned before, performance, bioplausible, and if the model's fair. So yeah, so far through this process, we have managed to co-develop, approve, and operationalize 3 different risk prediction models for COPD into live clinical care, which is great. So the first of these is a mortality risk prediction model that has a kind of 12-month prediction window, so predicting if someone is at risk of death within 12 months. The next model is looking at readmission risk at the point of discharge from hospital within 3 months, and the last of which is looking at admission risk within 12 months for all patients, regardless of if they've had a previous admission. So these models all have slightly different functions in risk stratifying patient cohorts, but in all cases, the idea is the same: to risk stratify, look at explainability to determine determine actionable traits that can be used to reduce the risk of these events and improve patients' care to make sure as much as possible that these events don't happen. So yeah, 2 of these are calibrated XGBoost models, and one's an uncalibrated light GBM model for those of you with a machine learning interest. So yeah, the way that the models are currently used is within COPD specialist multidisciplinary team meetings. So these include consultants and senior nurses. So these are really specialized people that know a lot about COPD, and the patient population we're running it on is people that are a very high risk cohort that are on a long-term monitoring service. And the way that the model inferencing works is the inferencing will be run, and during the meetings, the latest model scores and accompanying explainability insights are reviewed to determine what, if any, alterations could be made to reduce the risk of the different patients. So these models are shown through a custom dashboard developed by software developers at Linus Health. So this is a sort of custom fit which shows risk score and explainability for all the different patients for the different model scores. So this has really been a huge success within NHS Greater Glasgow and Clyde for this kind of high-risk cohort, with the models being used in secondary care, so within hospitals by really specialist people. And the success behind this got us wondering where else we could use these models, and how else we might be able to display model insights in order to overcome some of the hurdles that arise when trying to introduce completely new software into the NHS, and also display the insights in a little bit more of a digestible way for non-disease experts. So yeah, in answer to the first question that we had about potentially an alternative method, this is how we came to explore Power BI. So just quickly, why Power BI for this context? So, Power BI allows you to create very customizable views with a range of functionality relatively easily. Also, it removes the need to create these kind of bespoke user interfaces, which are brilliant for certain use cases, but potentially if you want to get software or you want a tool to be available in the NHS, there can be a lot of regulation and considerations around integrations and so on, which is one factor. And also, they're relatively easy to share with different stakeholders compared to having all that setup time. So that's the advantages. Obviously, there's advantage to having the bespoke user interface as well, but this is why we explored Power BI. So yeah, in terms of the second part, where else in pathways these models could be used, where else in care pathways these models could be used. This is where our use case comes in. So this is risk stratification within GP practices or general practitioner practices in primary care in the UK. So yeah, for those of you that aren't aware, GP practices are kind of local centres that people attend for regular checkups when they have more mild illness in the UK, or if they're going for a review, for example. So patients with chronic conditions, so things like COPD, asthma, heart failure, and so on, are supposed to receive annual reviews within GP practices, which are in the local area, to determine if they are receiving appropriate medication and to provide any medical advice if required, or refer them on to appropriate specialist services that can offer them advice. So yeah, during these appointments, alterations to their prescriptions can also be made, and they can also be recommended or referred on to specialist programs to help them manage their condition. So additionally, there's a lot of patient data that's collected during these appointments, which is really useful for tracking patients longitudinally. So it's not great if patients aren't having them, and this data could also be used to train machine learning models. So yeah, all comes full circle in a way. But yeah, based on a lot of the issues I described at the beginning of the talk, the constraints on resources available to healthcare teams mean these events can only happen for a small subset of patients, a very small proportion, like sort of 20% in some cases, and there's a postcode lottery element with certain GPs managing to arrange a larger portion of these annual reviews than others. And because these are local centres, this can lead to healthcare inequalities between different postcode areas, which is not good. So yeah, for some individuals, missing this appointment can have a catastrophic implication. They're not getting that review, that updates to their therapy, getting recommended to these services. That can be catastrophic, and they can quickly land up in hospital. However, for other patients who maybe have less severe disease or their therapies are already optimized, there's kind of less value to them having these time-based annual reviews. So yeah, there's therefore a lot of value in risk stratifying these patients so that they're carried out on a needs basis rather than a time basis. However, in primary care, there's not really a very easy way to do this. So yeah, this is where risk stratification could come in. So yeah, it's very difficult as well for those overseeing or coordinating different GP practices in certain geographic regions to understand the populations that are different GPs with COPD in terms of the risk profile they have, the demographics of the population, and how frequently review events are taking place in those GPs. And what level is being collected at these reviews as well. So sometimes some of the information should be collected is not being collected even if they are having the review. So yeah, there's also value in providing this information to these primary care coordinators so they can ensure that the resources are put in place to allow for reviews to be carried out on the most high-risk patients across the different GP practice locations. So yeah, the co-designed user interface that I mentioned before that's used in the secondary care setting with a specialist is a great tool for this context. But in primary care, in the UK, the clinical care team are not disease specialists of the specific disease indication that you're looking at, and maybe not that familiar with the specific COPD population or heart failure population that they have in their GP. So an alternative means of conveying the information that the models show is required for these groups. And also those overseeing the different GPs are not necessarily disease experts as well, and will have different wants from the data and machine learning insights. So due to this need, we've created two different Power BI dashboards, one to be used by the individuals that are working in primary care in a specific single GP practice, and one for those overseeing different GP practices. So I'll now talk through the requirements of these views, providing context with screenshots from the proof of concept dashboard that I created and will demonstrate shortly. So the first dashboard is for those that are overseeing multiple GP centres to get an idea of the risk score distribution of the different GPs in the area to understand if there's a disproportionate number of high-risk patients in one GP. So that steps can be taken to address this in order to combat healthcare inequalities. So you can see a screenshot from the dashboard here and distribution of the risk of mortality model predictions across the different GP codes to see the differences there. You can see it's a lot lower in GP code 4 and slightly higher in GP code 1. Yeah, another thing that is really important is that there's kind of buy-in from everyone that the models are making sense in terms of the predictions they're making. So also provide a global model explainability view that's kind of simplified, and I'll show some features when I get into the demonstration that I've added to that view in order to allow it to be more interpretable by those overseeing multiple GPs. Yeah, so they also need access to demographics information around the patient population, so they can kind of look at there's any kind of relationship between that and model predictions, to kind of keep an eye out for healthcare inequalities. And there's also really important that they can see missing data levels, so it's clear kind of what levels of reviews are being done in terms of the number, but also, as you can see, there might be different levels of key information that's being collected at these reviews. So if there's any systematic missing data, they can kind of put in steps to avoid that. They also need to keep an eye out for missing labs tests, which are kind of biological measurements that can be taken in order to track patients across primary and secondary care settings. So look if certain patients, certain GPs aren't having these done often. So yeah, the second view is the primary care provider, so somebody working at the individual GP practice who will be actioning these reviews. So yeah, they need to see a more kind of granular view of risk profile across the cohort, so they can understand the population that they have with COPD in this case, in terms of if this is a particularly high-risk cohort or maybe not so much. They also need a quick view that allows them to quickly identify the highest risk patients, such as something like this, which I'll get onto when I got onto my demonstration. Yeah, they also need a view of the demographics of the cohort, again, so they can explore potential relationships between demographic factors and risk score, and also yeah, just so they can kind of understand what the population is that they have in their GP, if that's kind of an older population or things like that. Then yeah, they also need to understand missing data levels so they can see from their own perspective within their practice if there is certain components of the reviews that aren't being conducted. They're not collecting, for example, MRC score, which is typically a metric that you'd want to collect during those reviews. Yeah, something else that they'll want to understand, as they're the ones conducting the reviews and potentially enacting changes to therapy, is the kind of clinical events and also clinical interventions that the patient population that they have are on. So this again gives an idea of severity of the disease, in this case COPD. If patients are having a huge number of admissions, and that distribution is really showing that, but it also allows you to filter and look at, for patients that are having lots of admissions, what interventions are they on currently, to see if there's any kind of systematic gaps or things that could be done differently to make sure the best therapies are being offered to patients, or if there's any easy wins in terms of referrals and so on. So yeah, the last thing, but something that's super important, is the ability to have that kind of individual view of a single patient for those who are working in that GP practice doing the reviews, because this information can help support those reviews. Yeah, in terms of giving a picture of a patient in an easy place, and providing a view of explainability of why this patient is considered to be at the risk where they are, so they can risk stratify in order to bring forward certain patients, and then they can go into the risk or see, why is this patient high risk? What can I do about it? So we can show this through local level explainability, kind of what I've shown before, but also we can go a level further, and something that we're exploring at the moment is looking at suggested actions off the back of the explainability. So it's tied into explainability, but it's slightly different, and it's based around making simple recommendations to patients. For example, the patient's already on triple therapy, so no pharmacological therapy changes can be made, but the patient hasn't attended pulmonary rehabilitation, so referral to that is recommended. So really succinct insights and actions for teams that don't have a huge amount of time. So yeah, I will now go on to the dashboard. Yeah, so I'll just switch screen and talk through the views that I've created in a bit more detail, and also explain how I created those. So I'll just jump off and switch. So yeah, you should be seeing the dashboard now. If you can't, then let me know. I'm just going to talk through the first of the pages. So we're going to start off with the multi-patient level view. Yeah, so I've kind of talked through this before, but this is kind of breaking down the different patient cohorts at the different GP practices for those coordinating them. So you can see the number of patients, you can see the average risk as predicted by the model, that if they're at risk of mortality within the next 12 months. So you can see that for the different GPs, and you can also see that view of how does the model determine risk of mortality, so that explainability. So yeah, we've got this view here. I've added some tooltips here, so without leaving the page, they can also get a better idea of not only the average risk, but the distribution across these different centres. I've also added, as I mentioned before, to the view of model explainability. tooltip here, which is kind of adding a bit more context. So this is really important for sort of getting buy-in that the model is actually making sense and there's value in it. So the top features here, you can see that if they've had a longer length of stay due to COPD in the previous year, they've had a lot of readmissions. If they're older, risk of mortality is increasing, which makes sense. Conversely, you can see if they haven't had pulmonary rehabilitation, if they have had pulmonary rehabilitation, that reduces the risk score. So to add some context to each of these, I've added these kind of custom tooltips here. So yeah, that shows high risk values are typically high. So are they numerically high? So it makes sense that if their length of stay is longer, that their risk will be higher. I've also added feature details, so a bit more detail on actually what the feature means. So length of time spent in hospital in previous 12 months due to COPD, and yeah, as well, just the average impact on model predictions across the cohort. So how much that feature is changing the model prediction typically. So just quickly to explain, I created these tooltip views by just going to create a new page. Then you can go into the page itself and just go into here, page information, select allow use as a tooltip. You can then change the size of the page in order to be the size you want. For each of these, for the first one where I had a visualization, I just set up a visual as you normally would by dragging in the different fields. For the other one, which kind of provided a bit more context to each of the features, what I did was simply insert a text box, and then you can just type high risk, low, high, kind of what I had before. Then you can go on, select value, and go into type, and you kind of use the Q&A functionality in order to find the column it is that you want to show. So it's not coming up, but yeah, that's the idea with that, and that's how I created those views there. So I'll just delete this and go back to the view. So yeah, something else that I've added here is the drill through functionality. So obviously they want to have a view of individual patients, like they could see GP code number 1 and see that their risk score is higher than others. So they could go drill through, and there's two options here. There's kind of the demographics and risk score view, and there's missing data. So I'll just go to demographics first. And that allows you to have a look at the demographics and also the risk score across the population. So you can kind of have a look at, for the different age groups across SIMD quintile, how that will change the model risk score to look if there's any relationships there. Yeah, and that provides more sort of detailed view of risk score distribution across the population. I've also added these options here, which allows you to jump between the different pages while keeping the filter. So I'm just going to switch to missing data levels at the GP using this. So again, as I mentioned before, what we're wanting to look at here is these factors which are related to the review itself, smoking status, CAT score, so on, but also missing labs tests in the last 2 years. Because that's really important data to capture as well. Yeah, I've set these up with conditional formatting, so you can kind of see here that depending on the level of missingness, you can see that there is a color change in the bars that are shown. So you can set that pretty simply just by going on to visualization, going down to here, going to the columns and going to color and setting up f of x, and then you can just customize how you want this color to work. I think it's a neat feature for being able to show the levels of missingness in a different way, or whatever it is you might want to show for your own use case. So we'll just quickly talk through how I made these buttons, because I think that can be quite useful to do. So essentially, you just go to make these buttons. You can go into insert. You can then go on to insert a button, and you could go blank, and then you go to the settings of that button, and you can set up you can go to action, turn the action on, and then you can set that to navigation, and then set the destination to the page that you are wanting to go to. And I've just set that up for the two different ones. If you do this and you want to keep the filters, you will need to change the action on the back button as well, which is something to note. So to do that, you just go onto the action of that, and you push it away from being back and put it to page navigation, and that way you can go back to the sort of overall cohort page with the different GPs, rather than jumping back and forth between the two different pages. So yeah, that's something to note. So yeah, that's pretty much it for that view. I'll now go on to the individual GP level view. So the individual practice, the people actually doing the reviews. As I mentioned before, you're kind of wanting to look at demographics and the impact of that on risk score. So this is for GP code 1 again. And yeah, they've got a more granular view of risk of mortality, and they've also got this key addition here, which is the top 15 highest risk patients. So this allows them, the person who's trying to prioritize patients for the review within the practice, to be able to look through the patient population, or see quite quickly, I should say, which patients are the highest risk of mortality in this case, and then access data about those patients. And I'll get onto that sort of drilled through view of the individual patient in a second, but I'm just going to chat through this first. So just quickly, there's also conditional formatting applied here. We wanted to make it as clear as possible to those who are stratifying the population, who the patients are that are at the highest risk. And in order to do this, we added a bunch of features here. So the bar length, for example, is proportionate to the model prediction, so risk of mortality, and also we've added conditional logic. So red flags will appear for people over a certain threshold of risk, orange flags for those above another threshold. You kind of see that more clearly if I jump between the different views, and orange and white flags for those that are above a slightly lower threshold again. So just quickly, how I set that up is by going to here, you can go to predictions, so the columns within visualizations, go to conditional formatting, then to set up the data bars, you just select data bars like this and the colors of them. To set up the icons with the conditional logic I did, I based that off the prediction field and just set up a bunch of logic. So if it's over 0.2 and below 0.45, then show that orange and white stripe flag, and so on, with all those different rules there. So again, I've set up those kind of buttons which I showed before, navigation buttons to jump between the different views more easily. So I'll go on now to the clinical events and interventions view. So yeah, this is looking at different events, so admissions, but also exacerbations, which are essentially periods where patients' disease gets temporarily a lot worse when they have COPD and they need to take particular medications. So you can jump between looking at admissions or exacerbations depending on what the GP is more interested in looking at. Also, you can see kind of key therapies. So are they on triple therapy, which is kind of a very strong inhaler, which is used for patients with more severe disease. You can also look at factors like if they've had their inhaler technique assessed, if they completed pulmonary rehabilitation, so that program to help them manage their disease better, if they've been given smoking cessation advice, if they've got a self-management plan, all these kind of factors. And because of the cross-filtering that Power BI offers. It's quite neat because you could go on to, for example, the more high-risk patients and then look at what levels of each of these have happened for these patients. So if I go on to this population, for example, they've had 7 COPD admissions in the previous 12 months, but very few of them have been given smoking cessation advice. None of them have completed pulmonary rehabilitation and so on. So this can allow kind of easy wins to be identified in terms of really high-risk patients within the GP practice and things that can be suggested at the review kind of on a wider level to improve care. So just quickly how I set up that button is by setting up bookmarks and creating a bookmark navigator. It's quite useful if you don't want to leave a page and you want to be able to show different data and visuals without getting too cramped. So essentially the way I did this was going to selection, one of the panes here, and essentially what you can do is you can put 2 visuals on top of each other, then show and hide different visuals, and then create a bookmark in each of the alternate scenarios. So you can see here I've created these 2 bookmarks, show admissions, show exacerbations, and in each of these I've hidden the alternate visual in order to jump between them, and then you can simply go to insert, again, buttons, navigator, bookmark navigator. If you're wanting to do this for different pages, something that you'll need to do is go to bookmark navigator, and you can see all my bookmarks are there, which is maybe not what I want. That's super cramped and those 2 aren't relevant. So what you need to do is go to the bookmark onto the format pane and then select group by, the group that you're looking at rather than all. So that is how that works. I'll just jump to the final of these sort of GP level views, which is the missing data view. This is kind of fairly self-explanatory. This is the different types of information that should be collected during these reviews, and this is just looking at if there's anything that's systematically missing, like MRC score is a lot lower in these patients. So it's kind of a reminder to those at that GP practice that data needs to be collected as part of the process as well. And this also just gives an indication of the level at which these events are happening, so these annual reviews. I'm now going to jump into the drill down view, which will be the last part of the demonstration. So this also has a tooltip, so you can just quickly see, should have mentioned that, sorry, a quick overview of risk for these patients, what factors are driving the risk score. So if I drill into this patient, for example, go to drill through individual patient, it will take me straight through to that patient. You can see they've got a really high risk score. So that's why they're in the top 15. I've added kind of a text element here that allows you to see key information for that patient. So 76 years old, they're male, IMD 2. Have they complete pulmonary rehabilitation? They haven't. They haven't had their inhaler technique assessed, and they are a triple therapy user, or they're not a triple therapy user. Never mind that. So essentially you've got the explainability view here. So this is explaining the top 10 factors impacting the patient's risk score. Again, I've added those tooltips just to add a bit more context to what each of these features represent. So then to support the review, the GP can use this information to work out what's driving the patient's risk score, what they can intervene on using the insights provided by machine learning. But they also have this other view here, which I kind of mentioned before, which is associations and actions, which are kind of simple rules that should be implemented in order to sort of provide quick insight to what can be done for that patient. So if there's real-time constraints, certain things can be done. So for example, patient is already on triple therapy, so no triple therapy changes can be made. But the patient hasn't attended pulmonary rehabilitation, so pulmonary rehabilitation is the advice in that case. Just quickly, I'll jump back. There's also another view, so the GP doesn't necessarily have to use that drill through, and they can just go and select the CAI number, which is a unique identifier, to find the patients and get the same information for any patient they may be interested in looking at. So yeah, that kind of wraps up my demonstration. I'm just going to switch back to my slides and conclude. Should be on my conclusion slide. Yeah, hopefully it is. Machine learning models, to conclude, have the potential to alleviate some of the issues facing healthcare systems by providing crucial insight to clinical care teams and stakeholders who have different data needs. This can work really well through different means, such as what I presented before, with a bespoke user interface being created, but Power BI has a potential role in providing a more simplified, intuitive, and easy to provide way to share those insights with different stakeholders with different expertise. So yeah, a combination of these factors can hopefully work together to mean more models are available to clinical care teams to help risk stratify patients, improve outcomes, and alleviate a lot of the stresses on healthcare services. That's the end of my talk. Thank you very much for listening, everyone. Thanks a lot to my mentor, Cohen, and also to New Stars of Data for allowing me the opportunity to speak today. Let me know if you have any questions. Thanks very much.